How's it going, Web?
Good, how are you?
Great. You got going here? You got a bunch of people on there.
Say that again?
Ready to get going? Looks like we got it
Yeah, yeah.
going.
Yeah,
All right, awesome.
good to go. So I'll take over.
Yeah, go ahead. Let me give you a quick intro.
Sure.
Welcome everyone to Mirror Grand Rounds. We've done this a few times now, where pulling together mirror site PIs and other leaders in the field of intracerebral hemorrhage management to talk about minimally invasive ICH evacuation and other new innovations in minimally invasive ICH. And today, we have with us Dr. Webster Crowley, professor at neurosurgery at Rush University and director of the cerebrovascular and endovascular division there. Webster's got an interest in the different types of devices that are used in minimally invasive ICH and is going to talk to us about some of the outcomes in mirror as well as some of the other outcomes in the space using different devices. Go ahead and kick it off.
Awesome. Thanks, Chris. Let me make this slideshow. Is this coming off? All right.
Yeah, looks good.
Great. Although I think can I do it where oh yeah, it's good. Okay. So great. So yeah, Chris, thanks for asking me to do this. As you mentioned, I am particularly interested in the device and since we've had a number of these, obviously, I'm not going to go into a lot of the kind of specifics of the trial itself because that's been gone over a bunch of times. But my particular interest in presenting something maybe a little new is comparing the different sizes of devices, and that was borne out largely the fact that I'm not an endoscopic guy. Like I don't do endoscopic work. I don't do ETVs. I don't do third colored cyst through it. I just don't do that type of work. That's not something. Obviously, I did a bunch of. I mean, I trained at UVA. I work with Ed Laws and John Jane Jr. and so we did a bunch of endoscopic kind of pit stuff, but not like tubular, like through the channel type of endoscopic stuff, and certainly not in my practice. So I've always kind of gone for the larger one that allows me to use to use two hands, and so. Not to say that I do that all the time, but I have favored that, and obviously I'm interested in knowing if that's the right way to do it, or if there's any kind of data that suggests that I should overcome my disinterest of using the smaller port and switch over to that. So just to review the endpoints of mirror, right? Because this has again been discussed a bunch in the past, but primary endpoint is the rate of technical success defined as reduction in hematoma volume to less than 15. Am I doing this? Sorry, I'm gonna try to get rid of this thing that shows all of us on the side. Uh-oh, there we go. To 15 milliliters on the post treatment CT of the head. Secondary endpoints: percentage of patients achieving MRS scores less than or equal than 3 at 6 and 12 months. The length of ICU stay is obviously something that has always been associated with ICH evacuation. Safety endpoints: mortality at 30 days, rates of rebleeding, surgical site infection by 30 days, and overall survival at 12 months. For this, it's again kind of like a cursory analysis, but we'll kind of look at the primary and secondary endpoints more than anything. So I wanted to show a couple cases, but these are the devices. So the options here: 15 millimeters versus 9 millimeters. I think it was 8 and now up to 9. Obviously, the 15 millimeters are a little thicker. They require more than a standard burr hole, and are generally not as long as the now 9 millimeter devices. But this is a 15, and this is an 8/9. So a couple cases here. So this is a 53-year-old woman with no prior medical history, presented to outside hospital after being found down in the shower. She was nonverbal. She was localizing her right side upper extremity and withdrawing her lower extremity, and became progressively less arousable. This is the scan that we have here. You can see the we don't get those reports anymore, but the 35 cc ICH volume, kind of anterior basal ganglia, um, but uh, but certainly worthwhile to take out. We performed a left frontal craniotomy, a small curvilinear incision behind the hairline, and used the 15 millimeter 80 millimeter device. This is the post-op there. The ICH volume was not detected afterwards. So they said there was obviously there's a little bit of blood, but essentially down to zero. Uh, and I was quite happy with this. Here's some pictures showing kind of the size of the craniotomy, location of the craniotomy. So not big, but obviously bigger than a small burr hole. Patient was able to transfer out of the ICU on postoperative day 2 and was able to discharge home shortly thereafter with an intact exam. So this is obviously kind of an extreme case, but a good one. 77-year-old man, patient number 2, who presented to outside hospital with altered mental status, was intubated due to his level of consciousness and was withdrawing his right arm and flickering his his leg to noxious stimuli. This is a different bleed. Obviously, there's not a ton of shift, largely due to probably his age and the atrophy is clearly multiple different ages of the hematoma. The heterogeneous hematoma, but a large one. So the ICH volume, as detected by this, is 63 cc's. This one, again, low bar, you're not going through what you're going through for the deep ones. Did a left temporal craniotomy with curvilinear incision behind the hairline. Used again a 15 by 80 millimeter. And again, no detected ICH afterwards. This again is a small craniotomy that you can see there. The incisions maybe bigger than we had to do, but all behind the hairline and a much smaller craniotomy than we otherwise would have used. Was extubated on post-op day 1. Spent a couple days in the ICU, but more for agitation, so we required some prosthetics for that. Was discharged to acute rehab on postoperative day 8 with intact strength and speech and a little bit of disorientation, and went home 3 weeks after the surgery. One last case here. This is a 45-year-old woman with no prior medical history who presented outside hospital with facial droop, aphasia, and left-sided paralysis, and a right-sided basal ganglia ICH that was 20 cc's. We hear about I don't have the images to show from the outside hospital, but we hear about these patients typically from when they're coming in. Most of our patients are transferred into our hospital, so we get a heads up and we kind of said, 20 cc's. There's probably not going to be a role for this. But if it expands at all, then maybe it'll be a good candidate for the trial. They did intubate her at the outside hospital. By the time she arrived to Rush, she was triple flexing on the right, had no movement on the left, had a blown pupil with a scan showing a much enlarged bleed. But unfortunately, she was no longer eligible. I think it was the blown pupil. I think this is not someone that we enrolled in the trial, but certainly someone that we did the procedure with. 56 cc's. So obviously a kind of a rapid, pretty large increase over the time that took to transfer, which was not a ton of time. This was the bleed. It's a little this little kind of island over here. There's not a clear connection with that, so that's a little confounding, I guess. But obviously related. Maybe some a little bit of hypodensity above, but this is a much larger and pretty acute bleed. Sorry, I didn't write that here. Did a 9 millimeter by 130 millimeter device. The small burr hole you can see here, and again here on the X-ray you can see the burr hole went through that, and had a 13 cc residual. So while technically this is this would have been considered, in the primary endpoint, the positive thing. This to me seemed like a ton of blood that was related. Sorry, that remained. So I was not pleased with this, although obviously no shift. So it took off some of the pressure, but for me, I was unhappy with this amount of residual. Again, even though it technically meets the end, or would have met the primary outcome of being less than 15 cc's for the trial. This again is that other island that's there that was kind of untouched. So her postoperative course, she was in ICU intubated for 9 days. Her discharge NIH was 15 as opposed to an admit NIH of 23, and her MRS was 4. She was discharged to rehab at 23 days. I saw her a couple weeks ago, actually, and she's still wheelchair bound. She's got 2 out of 5 strength in her left leg, 1 out of 5 left arm. I mean, she's having okay conversation with you. She still has a little bit of residual aphasia. She's left-handed, but definitely affected, and again is still wheelchair bound. So obviously the 15 millimeter surgiscope is far superior than the 8-9 millimeter device with regards to the residual volume, postoperative MRS, and length of ICU stay. That should finish up it. Chris, any other questions at all? Except just kidding, of course. So that's purely anecdotal. In my hands, in my experience, I've always said, hey, the large device is just much. I'm happier with the large device, and clearly it's anecdotal. I don't think I could have reached that large clot from the interior, going through the forehead with the size of the device that we have from the 15. So the length definitely makes a difference. Pause here for a second. I need to. There you go. Hide the video panel. Okay. So this is the data that the team gave me, where their analysis so far of the devices. A couple of things to keep in mind. There's a lot more of the 8-9 millimeter devices that have been used than the 15 millimeter devices, at least as part of the trial. The data is quite good, I think, for the 8-9 millimeter devices. Again, here we have overall, we have low bar and we have deep. So this is 60 patients overall that got the 8-9 millimeter devices. Again, they started at 8 millimeter, I think went up to the 9 millimeter. Here's the preoperative NIH, which obviously is a little lower for the low bar and a little higher for the deep ones. The premorbid MRS. There was, 0 people who had an MRS of 2 in the deep there. The preoperative volume, this is I think again, nothing is statistically significant right now, but this is a big difference as far as the low bar versus deep for preoperative volume. The low bar volume of the patients that got 8-9 millimeter devices was significantly higher with the low bar than with the deep. Post-op volume is great either way. 9 overall, 9 and 8. This surprised me a little bit that the deep was had lower numbers than the low bar, but again, this I assume will not meet statistical significance just yet. But the primary endpoint, this percentage less than 15 milliliters, 88% of people with use the 8-9 millimeter devices reached the primary endpoint, and that was consistent over low bar and deep. The 6-month MRS, again, this 0 to 3 is one of the secondary outcomes. At 6 months, this was 52 patients. Obviously, not everyone's reached the 6 month by the time of this analysis. 38% of patients had 0 to 3, and let's see, 12 out of 27. Yeah. So this is, I gotta look through that again. So the numbers here. So obviously you expect the deep patients to have worse outcomes in general. So that's no surprise there.
Yeah, that's the patients who got to the follow-up. It says N over 27 at the top, but that N for that row is not 27.
Right. Thank you. Okay. So
it's still
52% and
52%.
28%.
Yeah.
Thanks
Sorry,
for that.
that's not clear. Yeah.
No, I had a, yeah. brain pause there for a second. So 52% of people with low bar have 0 to 3 at 6 months, and 28% of deep. So again, that's not surprising, those differences there. When you look at the 15 millimeter device, a couple things stick out here. The of note, and I'll kind of highlight this a little bit later. The preoperative volume was a lot higher in the deep lesions than even the lobar lesions, but definitely deeper than they were, or sorry, larger than they were with the smaller scope. Postoperative volume is less than, less of a difference than was with the 8.9 device. So the 8.9 device was around 9, and this is higher. The average for this deep one was teetering on the on this primary outcome here. So 65% of patients reached the primary outcome overall, 75% of the deep, and 62% of the low bar. Again, the deep was like 4. So, right, these numbers are not going to be significant in any way, not statistically significant in any way, but I think uh, gives us information that makes sense to look into, right? It's not a clear cut. I truthfully, again, I would have said that there's no way that the larger device results in higher ICH residuals than the smaller device, just because you can get in there with patties, you can get in with bipolar in a way that I think is easier, certainly in my hands. And the 0 to 3 MRS, no patients in the deep one, 29% of the patients in the lobar ones. So kind of the comparison here, the primary outcome, again, percentage less than 15 cc's. The smaller scope reached 88% versus 65% with the larger scope. The preoperative volume was 54, about 55 for the larger one and 44 for the smaller one. The postoperative volume is again lower with the small scope than with the large scope, but the obviously you could say, well, the difference, the actual volume removed was larger for the larger scope, so it'd be 41 versus what's that, 35, and the percentage MRS less than 3 to 6 months was better for the smaller group than for the larger group. A couple of things that kind of made me, other interesting things that I wanted to compare out of that table and perhaps could contribute to some of these differences we're seeing here. The preoperative deep volume, again, was a lot higher for the 15 millimeter device. Again, this deep volume, I think there were 4 patients who had a deep volume, or sorry, who had deep bleeds that had the 15. So again, all needs to, you need to view it with that in mind. But there's a significant, there's a large difference between the volumes, at least in the cohort between these two. It's almost double, right? The preoperative lobar volume, on the other hand, are pretty similar. And these numbers here, the in the parentheses is the post-operative volume. So 67 down to 15, 34 down to 8. Again, that's a difference of 26. That's a difference of 53. So you could argue that the larger one maybe removed more of the volume, but again, that's hard to analyze just yet on the number of data. And the preoperative GCS 13 to 15 was 37% for the 8.9 and 18%. So again, double the percentage, at least, not double the patients, because there's a lot more patients in that small group, but double the percentage of people with the with that 8.9 device had a better sorry, no, this is pre-op. So the patients going in were better for the 8.9 ones, and so maybe that factors into why people decided they were going to use the smaller device versus the larger device. And again, if you have an ICH of 35, then versus 67, you'd expect their preoperative GCS to be a good bit lower. Conclusions, again, it's going to be hard to draw some conclusions from this. There is clearly no significant difference detected yet, or regarding tube size. I don't know what the number is going to be that's going to get us to that, but certainly not yet. I do think, obviously, in the absence of anything that says that we need to take one versus the other, physician preference and comfort can still be factored in. I do not have, again, the experience with the single, with the smaller port. As I mentioned, feel much less comfortable with endoscopic surgery than with open surgery. And as with anything, or as with a lot of the things that we see, physician preference can still be factored in. Although, perhaps in the future we'll have data that'll say no, everyone should be using these smaller devices. It may be reasonable to vary. Ultimately, this is kind of more of an opinion, but it may be that we decide, hey, for the deep bleeds, we're going to use the smaller port. That makes sense to me. That the lower ones, it probably, particularly ones that come to the surface, it probably doesn't matter if you use the bigger one or not. And if the bigger one allows you to get more clot out superficially, maybe we use the 15 for lobar and the 9 for deep, and then maybe we use the 15 for larger bleeds and then 9 for smaller bleeds, or some combination of the two, or maybe use 9 for everything in the future. But again, I just wanted to start a conversation with this, and just this is something that is not going to be certainly not solved from this data set. But I found interesting, because I would have 100% said, if you say that the primary outcome has nothing to do with MRS, that the argument I've always felt was compelling for using the smaller device than the larger device is the tissue destruction as you go through, right? It's not what you do when you get there. So I always assumed that perhaps the GC, or the MRS might be a little worse for the larger group than the smaller group, if there was going to be a difference, but that there was no way that the clot evacuation was going to be better with the smaller device. And so far, that doesn't seem to be the case. So I would be interested to get any thoughts on this. And obviously, some of you have a lot more experience with the smaller devices than I do, but it certainly hopefully starts a conversation, something we can get answers to in the future. So I'll stop there.
That's awesome, Webster. Thanks for putting that together. This is kind of the first data we've seen coming out of the Mirror Registry, so exciting to see it all.
Yeah.
In terms of what are the advantages of the smaller and the larger device? I think we have an assumption that the smaller device has less tissue damage, and that matters. And maybe, and I have a sense some of the data from the literature suggests that, with
But
MISTY
you mean
3
going in,
patients.
right? You mean once you get there, or do you
Yeah,
mean
yeah.
going in?
Well, that's a great point. Once you get there, also perhaps, but going in, you see the MISTY 3 data looking pretty good for a deep versus low bar, even though the trial itself is negative. And then you see the cranial puncture data looking really good for deep hemorrhages. And those are very low profile devices. So maybe to some degree it matters, and then maybe, it stops mattering after a certain number. But then once you get there, I haven't really thought about that before. But once you get there, perhaps with the smaller device, things close down more around you, and you have a harder time kind of seeing the entire cavity. Maybe that's one thing. As I've used the 15 a few times, I found that putting it right at the clot, it kind of gives you a good window and a bird's eye view of the whole clot. But sometimes when you go in with the 9, things kind of close down around you a little bit. It's harder to see around and really get a sense you got everything.
Do you say, when you say right at the clot, you mean like to the beginning of it? You don't go,
Yeah, like to the face of the clot. Yeah, on the way in. Yeah.
it's funny, because I've always gone to the deepest point of the clot, right, and then kind of like
Yeah.
found that interface and put it. And again, it's harder to do it with the smaller tube, but put a patty at that interface and then kind of work back.
Mm,
But
yeah.
Mark talked at, I forget when his grand rounds talk was, but how he likes to put it in the middle of the clot.
Yeah.
It's interesting how everyone does it. I think probably it makes sense for me to not go to the deepest. I that's not something I'm doing anymore. Kind of going more towards the middle of it, but I hadn't thought
Yeah.
about going to the beginning of it.
It would be interesting to see, an analysis of device diameter and outcomes. I haven't really seen that other than in individual studies. So I think that's something that, this is really the first time I've seen a device diameter comparison.
Yeah.
There was, I think there were a few patients in Enrich who got the smaller device. And so it would be interesting to see if there's enough to do a subgroup analysis in the Enrich data set between the
Yeah.
15 millimeter and the 11.5, right?
Yeah. I can't remember what I used for I think I used the bigger device for most of those as well, but yeah.
Yeah. Yeah. Any other questions from anybody? Let's see what we've got.
I will say
Well,
I spoke with
yeah,
our surgiscope dude earlier today, Peter, and my understanding is the 15s will be back on the shelf in the next couple weeks.
yeah, yeah. That's what I was hearing. We actually had some leftovers during that kind of hold and pause, and so I actually still had access to a few. So it was nice to still have those over the last few months. Any other comments from anybody else here? I see Kunal on the line.
No, I mean, I think I echo a lot of what Webster said as well. I use a larger tube as well, and I used to go down to the depth of the clot. Um, I haven't, we pick a trajectory so that when we use the larger tube, even if we damage some of the brain, it's typically frontal lobe or you know, inconsequential temporal lobe sometimes. But I had a lot of difficulty with the smaller tube in terms of maneuverability to actually remove clots. So that's always been our challenge.
Yeah, it seems like primarily you want to get as much of the clot out and control the bleeding, and then secondarily the size of the tube. But we don't yet know what the importance is of each of those factors.
And
And it may
anecdotally,
ju-
oh, sorry, go ahead.
no, I was gonna say it may just be that as long as you get the volume below that, then it doesn't matter. Or and therefore, if I have more success, maybe it's my series that I mean, I don't know how many patients I'd have to do in order to detect a difference in my experience, but I assume that if in my hands, if I feel that I'm getting it to a lower volume than the smaller tube, then I will use that. But Chris will use the smaller one, or what? I mean, I don't. But again, the
Yeah,
volume is something that we've always felt makes the most difference.
Yeah, I was gonna say anecdotally, at least, the larger tube, when you're done and you remove it, you typically still have a path all the way
yeah,
down to the bottom of your cavity versus the smaller tube, you typically don't. It actually closes a lot better. So, I mean, yeah, I have that feeling, obviously not panning out with data just yet, but I have that feeling that less of a footprint with a smaller tube.
At least for like for rehemorrhage, right? Like you kind of like, but it's not like I mean, at least I haven't seen a lot of like that pathway result in blood going down into it and filling the cavity again, right? I mean, I think, but I don't know.
Yeah, agreed.
all right, awesome. Well, we'll switch over to the closed door meeting for the study, and thanks everyone for coming to Mirror Gun Rounds.
Okay. Thank you.